Good morning, good afternoon, and good evening, everyone. Thanks for those who are coming on in to the fourth in this series of a KDIGO Genetics and CKD webinar series. And a little bit differently to the previous three webinars, this one is a little more, even more perhaps forward-looking than previous. And what we're looking at in this webinar, which is also a CME accredited webinar, as I'll talk about in a moment, we're looking at kidney genetics in 2025 and beyond, and looking further out into the field, reflecting on where we've come from and using that as a lens to look into the future of what are large and important emerging fields. And we have some amazing speakers today, if I can say. At the outset, would like to, of course, acknowledge that this webinar is supported by an independent educational grant from Natera. I'm Andrew Mallett. I'm the program director and moderator for this webinar series, and my disclosures are listed here. As mentioned before, this is a CME accredited program today. You can earn up to 1.0 CME credit. There will be a link in the Zoom chat to review the CME information. And at the end of the webinar, the CME evaluation link will be shared for those who would like to claim that credit. This activity is jointly provided by Global Education Group and KDIGO. So just keep an eye out for that link in the Zoom chat to review that CME education. I'm fortunate to be joined by three absolutely stellar colleagues and friends today, similar to the previous webinars. First of all, today we have Nina Knoers from the Netherlands, who is a colleague who needs very little introduction, who is a clinical and medical geneticist focused on kidney genetics, who has had perhaps, one would argue, one of the most impactful careers in this space, and has seen practically everything, I would say, in the last few years. And we're so fortunate to be able to draw upon her reflections. We also have Ulla Schultheiss from Freiburg in Germany. And Ulla is amazing and has a fantastic view in the adult nephrology space around kidney genetics and where this field is moving, particularly drawing upon experiences in clinical practice and also from the CKD Gen Consortium. And finally, Matt Sampson, who is a pediatric nephrologist from the United States, from Boston. And Matt has fantastic views and experience, particularly around the collision with polygenic components and understanding of the genomic architecture of kidney disease. Matt, through his practice as a pediatric nephrologist, additionally brings different perspectives into both where we've come from and where we're heading, which is naturally the focus of this session today. So three absolutely outstanding faculty who we're so proud to have with us to share their thoughts this morning. Now we will start handing over to Nina, if you have your slides there.
Okay, so thank you very much for this nice introduction, Andrew. So as an introductory talk, I will be talking about nephrogenetics, how far we've come and where we might be going in future. Let's see, why doesn't it make it here? So these are my disclosures. So one of the most important things of what genetics has brought us is actually an early and precise diagnosis. And we now know that genetic testing does not only have a confirmatory role, but has a primary diagnostic role. And this is really important for patients because it gives an end to the diagnostic odyssey, which can be very long in many patients, gives an answer to the why, can prevent, in some cases, invasive kidney biopsy and other further diagnostic testing. And with the use of the massively parallel sequencing techniques or next-generation sequencing techniques, we've seen that the diagnostic yield of genetic testing has significantly increased in the recent years. So it also has brought us other things, such as it facilitates prognostication and management. So for some cases, such as an ADPKD, some cases who is not caused by PKD1 or PKD2 variants, This means that the prognosis is probably much better when there are variants in other genes that are associated with the myelophenotype. It also allows the evaluation of potential extrarenal features such as diabetes mellitus and HNF1B associated disease. It can give clues for specific treatment such as CoQ10 supplementation in nephrotic syndrome associated with CoQ10 deficiency. It can guide the stopping of immunosuppressive therapy, for instance, in hereditary glomerulopathies. It's very important for the management of kidney transplantation, and of course also for family planning and reproductive counseling, and also for improved family care, for instance, the earlier identification of affected family members. And the yield is already high, and we actually expect it to become much higher because now we have seen that not only exome sequencing is happening in genetic testing, but also whole genome sequencing, and very recently also what is called long-read whole genome sequencing. And without going into further details, the importance of long-read genome sequencing is that it picks up variants that has not been seen by short read, such as complex structural variants, repeat expansions, methylation differences, and variants that are very difficult to map with short read sequencing. And long read sequencing has already proven itself also in kidney diseases, such as in Gittleman syndrome and in X-linked nephrogenic diabetes insipidus. So we expect that the yield, because of these new sequencing techniques, will again significantly increase in the coming years. So this is all very fine, but there are a lot of challenges still that we need to face before we can fully realize the benefits for all patients and families. The first one is data interpretation. I'll come back to that in a minute. And the next one is understanding why still in some monogenic diseases where we know the cause of the disease, there is this wide phenotypic variability. So people who have the same variants still can differ a lot in their phenotypic features. Then, of course, it's now time to develop targeted therapies, and Ulla Schultheiss will touch upon that subject. And there is a very important improvement in risk predictions for also complex kidney diseases. And these polygenic risk scores will be dealt with by Matt Sampson. And there's a lot of challenges still in nephrogenetics care, and because of time, I will not touch upon that in this webinar. So first, data interpretation. So data interpretation is still difficult. It is not at the moment, not sample in, diagnosis out. We need a lot of bioinformatics, sometimes functional assays in all kinds of models, and we need comparisons with large population databases, for instance, to find out whether the variants are indeed pathogenic. And one of the major issues in data interpretation are the variants of unknown significance, or the VASs. It's very remarkable that the majorities of variants that were initially reported as VASs following genetic testing for a genetic kidney disease were recently reclassified to be likely pathogenic. And this is very special because it contrasts with studies on VASs linked to other pathologies, such as in cancer, for instance, where the majority of variants initially reported as VASs were reclassified to be benign upon further investigation. Excuse me. So we don't know why this is. Is that a variation in study methods, or is this really something that is true? We have to find out in the coming years. Up till now, the American College of Medical Genetics and Genomics has recommended not to use VASs in clinical decision making and do anything to resolve its classification by segregation analysis in families, functional studies, and data sharing. So in 2020, during the COVID pandemic, the National Human Genome Research Institute did some bold predictions about human genetics by 2030. One was that the regular use of genomic information will have transitioned to mainstream, rendering genomic testing as routine as complete blood counts. To be honest, I'm not sure that this will ever happen, but we'll see. But the other one, very interesting, is that the clinical relevance of all encountered genomic variants will be readily predictable, rendering the diagnostic designation variant of unknown significance obsolete. So they believe that we will not have any VUSs anymore by 2030, so 5 years from now. This is, of course, very challenging. And in a recent review by Fowler and Rehm, they actually touched on that. Can that really happen, that variants of uncertain significance be no longer there in 2030? And actually in their review, they were indeed hopeful that many, if not most VUSs on the coding regions will indeed be resolved by 2035. And this is because we will have enhanced standard for variant classification that leverage a broader range of evidence. And of course, very, very important is artificial intelligence, which actually processes vast quantities of complex genome sequencing data and will then automatically identify the disease-causing ones. In addition, we will have growing availability of multiplexed functional assays, which can measure effects of thousands of variants simultaneously. So that means that you don't have to do a functional test for every variant separately, but you can do many variants in a gene together in these multiplexed functional assays. And finally, we will have increased data sharing. So hopefully by 2035, I think, indeed, these VUSs will be gone, and this will be a real improvement for data interpretation. So monogenic and complex kidney diseases actually exist on a continuum. And we'll be mostly talking about Mendelian diseases here in this webinar. But it's important to know that Mendelian diseases, although they actually are caused by major variants in a gene, they can, in some instances, also have a very, as I mentioned before, a very variable phenotype, which means that there are other potentially genetic modifiers that also are important to give this pathogenic variability. And one example is Alport syndrome. Excuse me for my flu. So for Alport syndrome, this is an example, and this will also be touched upon by Matt. So we know that single pathogenic variants in either COL4A3 or COL4A4 were previously described as resulting in benign familial hematuria or thin basement membrane nephropathy, but they were also identified in patients with Alport-like kidney lesions who progressed to kidney failure and were then classified as autosomal dominant Alport syndrome. But now we have some new key insights. For instance, these pathogenic variants are also found in about 1% of the general population. They are frequently identified in CKD patients because we are now using these very broad NGS-based kidney gene panels where these genes are part of. Then we've come to know that these patients carrying these pathogenic variants can have a wide clinical spectrum, actually ranging from really normal urinalysis to progress kidney failure and anything in between. There is large intra and interfamilial variability, and this also means that there is no definite genotype-phenotype correlation. And the disease progression and risk of kidney failure therefore remains unpredictable. It's very likely that, in fact, a polygenic background is very important for this intrafamiliar variability and this interfamiliar variability. And Matt Sampson in his talk will go back to that, especially also mentioning Alport syndrome. And with that, I'd like to stop and maybe take questions later, Andrew.
It's absolutely wonderful. And thank you so much, Nia. And that's a great reminder. So, as we're going through today, just as we're transitioning across to all the slides, pop questions into the chat box. In the last 15 minutes of the hour, we plan to walk through those together as a group. So, please pop them in as we're going through. Don't hold them back. But thank you for opening us up today, Nina. That was amazing.
For my flu, I have a flu, so I'm coughing all the time. So, but
Oh
I'm
no, I'm so sorry. We're so grateful to have your time though today. Ulla, if you're able to bring up your slides, we'll transition into this next section.
Okay, so thank you for the kind introduction, and many thanks to KDIGO for giving me a chance to talk about a bold future for precision therapies and genetic kidney disease today. Here are my disclosures. Before I delve into a new topic, I love giving a definition of what I want to talk about. So what is precision medicine? Precision medicine is a healthcare approach that utilizes molecular information like genomics, transcriptomics, proteomics, etc., phenotypic and health data from patients to generate care insights to prevent or treat human disease, resulting in improved health outcomes. Or saying this more easily, giving the right medicine to the right patient at the right time, meaning that this may be gene therapies, but not necessarily, and an emphasis is put on treatment, but also on prevention of diseases. Traditionally in medicine, we have the same treatment for all, leading to an effect in some, no effect in others, an adverse effect in the third group of patients. In contrast, if you look at innovative medicines, we want to personalize treatment. But how do we get to treating patients individually and personalized? This aim is in principle achieved by combining knowledge of disease mechanisms to define subgroups of patients who may benefit from specific therapeutic strategies. So you can think of this as maybe like a molecular fingerprint of patients, and we are slowly but surely walking towards this end goal. But the transition to these disease classifications based on molecular classifiers will require still numerous technological developments. For example, the integration of different data layers, high-dimensional omics data, pathology data, and prospective clinical data. And for this, we will definitely need computational advancements for high-throughput analysis of genetics or omics data. In addition, I believe that we'll see developments in digital pathology and computational image analysis, including machine learning approaches that will facilitate the understanding of the relationship between the structural changes and the molecular phenotypes. I think a prerequisite for this is our multinational initiatives to ensure that our understanding of the disease pathways is as comprehensive as possible, and that new recommendations for the classification and also the treatment of kidney diseases have global support. Another very important point is the long-term participation of patients, which is a key to the success of current and also future initiatives in precision medicine. But does this mean that this is all a dream of the future? I don't think so. I think we already saw in 2019 with the landmark paper by Brugman et al. Out of the Garabri group that the genetic diagnosis per se led to a clinical impact in 89% of cases. And this did not only mean informing the patients about their prognosis, but also changing transplant and treatment decisions. So these are things that we can do now without further research really being needed, but still, I believe that the implementation of genetic testing in patients suspected to have a genetic kidney disease is often lacking. And to me, this is not only due to monetary reasons or let's say insurance reasons, but I believe this is because of where we're coming from. Because if you think of ADPKD, for example, we're so used to diagnosing this via ultrasound or MRI, and I don't say that this is not correct, but we now know that about 5% of all ADPKD patients do not carry PKD1 and PKD2 variants. So I guess before we start something like tolvaptan, we should really have a genetic diagnosis to be able to personalize the treatment, because those other genes are probably not, I wouldn't say you should necessarily treat then someone with tolvaptan, and also total kidney volume as a measure for prognosis might not be the correct way to go in these other genes. But let's take a look at the development of targeted therapies in genetic kidney disease, because an ultimate goal in medicine is the development of curative treatments. And one of the most advanced examples in nephrology is the application of gene therapy for Fabry disease. 5 males with rare GLA variants have been treated with lentiviral-mediated ex vivo gene therapy, where hematopoietic stem and progenitor cells were transduced with a functional GLA gene and then reintroduced via an autologous hematopoietic stem cell transplant. And 3 of these patients are stable today with no need for enzyme replacement therapy. But there's more examples for targeted therapies, and we already heard about this from Nina. And there's a great example of RNA interference therapy for primary hyperoxaluria. But another important example is Alport syndrome, because it's one of the commonest genetic diseases in CKD. And many avenues have been pursued in research in Alport so far. There's gene editing on cells using CRISPR-Cas. There's exon skipping for X-linked Alport syndrome with truncating variants. But what I want to talk about now are drug-induced premature termination codon read-throughs. And these are this is a possibility that has been studied well before in other genetic diseases like cystic fibrosis or Duchenne muscular dystrophy, and a phase 2 open-label pilot study to evaluate the safety and efficacy of ELX02 in patients with X-linked or autosomal recessive Alport syndrome is on the way. And ELX02 demonstrated dose-dependent read-through on nonsense mutations to generate full-length functional proteins in vitro and in vivo model systems. But what do I actually mean by drug-induced premature termination codon read-through? So this is very simplified how this works. So usually you have a gene that does not have a pathogenic variant, and the MRI is translated to a normal protein by the ribosomes. If you then have a gene with a nonsense variant, you will have a premature stop codon leading to a truncated protein. If you then add ELX02, which is a small molecule eukaryotic ribosomal selective glycoside that acts to induce read-through of PTCs, the ribosome will read through the stop codon leading to a normal protein. All right, so now we want to switch gears and go from disease treatment to disease prevention. And the example that I want to give is on pre-implantation genetic diagnostics, or you can also call this pre-implantation genetic testing, so PGD or PGT. This is a possibility for couples where you have one affected, for example, with Alport syndrome, or parents who both carry a pathogenic variant for autosomal recessive Alport syndrome. And what you do is that the woman of the couple needs to be stimulated. So we'll have multiple mature egg cells that you can then harvest via biopsy. These egg cells will then be injected with individual sperms to create embryos. And we will then, or in our PGD center, we then watch these cells until day 5, the blastocyst stage. And here you can see the embryoblast that will be the later on child, and the trophoblast. And we don't want to disturb the embryoblast, so we use trophoblast cells to analyze the embryos for pathogenic variants. We then need to, on day 5, extract cells from the trophoblast, and this we do by laser incision, and we wait for the hatching. So 6 to 8 cells usually just migrate out of this little hole, and then it closes by itself. And these cells can be transported to the genetic lab. And here we use a method called karyomapping for analyzing the embryonic cells. And I'm going to show you a simplified version of how this works. And we are going to look at an autosomal dominant inheritance pattern. So here, I guess we could call this an Alport spectrum disorder. So we have an affected parent and a healthy parent and the pathogenic variant. And in principle, this method uses SNP-based haplotypes linked to the pathogenic variant by observing how chosen informative SNPs segregate with the variant. You can think of this as us checking for the here blue chromosome around the pathogenic variant and selecting then embryos that inherited the red chromosome from the affected parents. And this looks kind of like it can't be true, but the accuracy of PTD lies at around 89 to 99% for most couples. After we have now determined a healthy embryo, the embryo is being transferred to the future mother, and this usually leads to successful pregnancy outcome in 40 to 50%, mostly dependent on the surrounding fertility environment of the couple. And with this new baby, I'm at the end of my talk. Thank you for listening. I'm looking forward to questions later.
Fantastic. Thank you so very much, Ulla. And next up, Matt.
Great. Let's switch gears to polygenic risk scores. So the vast majority of genetic testing that we do in nephrology is to identify mutations that are, or genetic changes that are extremely rare or absent in the population, but when they're present, they cause disease. What I'm going to talk about with polygenic risk is the concept that all of us have within us a collection of genetic changes that cumulatively may increase our risk of developing a disease or progressing with a disease once we have it. So that's what I was just talking about, polygenic risk scores. So the concept is that across our 3 billion base pairs, there are a number of spots in the genome where genetic changes can be associated with a small amount of protection or a small amount of risk for disease. And using mathematical approaches and genome-wide genotyping, we can integrate or add the effects of all these disease-associated variants to determine the overall risk of developing a particular disease. So let me talk to you about this with pictures. But first, we're talking about the idea that these variants can be present with genes of known function. However, there can also be variants in genes that aren't associated with disease at all. So for instance, there are known single gene causes of chronic kidney disease like PKD1 or other Mendelian forms of disease, but there are also genetic variants in non-Mendelian disease genes that can lead to it. So here's the idea. So let's say that we're talking about chronic kidney disease. And let's say this is the entire population of Boston where I am right now. If we did genome-wide genotyping on every single person in Boston, we know at each spot in the genome whether there is increased or decreased risk for chronic kidney disease. What we simply do is add up each individual's personalized risk, and you will have a normal distribution. And you'll have some individuals in Boston who have a high polygenic risk for chronic kidney disease, some with a very low risk, and most people will fall somewhere in the middle. Now, this has been theoretical for many years, but we're now starting to understand how this may help us understand risk, clinical application. So this is a study about hypertension in 2021, where we had genetic information on genetic changes that increase the risk of hypertension. And Vora and his colleagues divided all the individuals in their study population into 5 groups. So the highest polygenic risk score here in peach, all the way down to the lowest polygenic risk score in light blue. So using only DNA, they said, are these people at high or low risk of hypertension? And then they looked over time at the incidence of hypertension over 4 decades. And they found, in fact, that those with the highest polygenic risk score for hypertension had the highest incidence of hypertension, whereas those with the lowest risk had the lowest incidence. So the point is that encoded in our DNA is risk for the development of a disease over time. Now, this was very exciting, and we wondered whether this matters in chronic kidney disease. So our colleagues at Columbia University, led by Christoph Kierluck, and together with a lot of other collaborators, created a genome-wide polygenic risk score to predict chronic kidney disease across ancestries. So they had genome-wide association studies of CKD. They had information on millions of SNPs. And in their ultimate study, they took 20,000 individuals with chronic kidney disease, 103,000 individuals without chronic kidney disease, and these were across populations, so white individuals, Black individuals, East Asian individuals, etc. And they divided these individuals' polygenic risk score into the top 5% of the polygenic risk score. So the top 2% and the top 1%. So these individuals, out of the 102,000 individuals, these were the top 1,000 individuals in terms of polygenic risk score. And they found that the individuals with the higher polygenic risk score for chronic kidney disease had a higher odds for disease. So what you can imagine is if instead of recruiting these cases and controls, at birth, if you did genetic testing on these 120 newborns, just by their genetic code, you could produce an odds of developing disease. So this is all done in the absence of Mendelian disease, but our previous speakers and throughout the seminar, we've learned that there are hundreds of Mendelian kidney disease genes. And what we wonder is the background polygenic risk score, could that perhaps influence the development of Mendelian diseases? So again, our colleagues at Columbia, led by Christoph Kirilluk, published a paper that showed that, in fact, this was the case. So let me walk you through this. This is my second to last slide. So they looked at patients with autosomal dominant polycystic kidney disease variants and individuals with Alport syndrome variants. So they did a really rigorous job of only looking at loss of function variants in PKD1 and PKD2, which cause ADPKD. And they said, are individuals in this cohort, tens of thousands of individuals, are they carriers of PKD1, ADPKD mutations? So all these individuals were carriers, and all these individuals were not carriers of PKD1. And then they assigned each of these individuals with their polygenic risk score for CKD. So these were people in the highest third of polygenic risk score, the middle third, and the lowest score. So the people who, the reference were people who did not carry PKD1 mutations and who had an intermediate polygenic risk score. Now, what they show is that individuals who have ADPKD mutations without a diagnosis and a low polygenic risk score have about a 3 times increased odds of developing having polycystic kidney disease. And however, if individuals carry PKD mutations and have a high polygenic risk score, they have about a 55 increased odds of disease. And the same thing was true of Alport syndrome as well. So what this showed is that individuals who carried Alport syndrome pathogenic variants, if their polygenic risk score for CKD was low, then they actually did not have increased odds of developing Alport syndrome. However, that unique combination of carrying Alport syndrome variants plus having a high polygenic risk score increased the odds of having disease. So this is new. It's a bit complicated, and we're now talking about causality and risk. But this is a paradigm shifting idea because historically we've thought that Mendelian disease is genetics' destiny. If you're born with a single nucleotide change in NPHS1 or PKD1, that if you have this change, you develop disease for sure. What we're showing here, what investigators are showing here, is that that's not necessarily the case. That for all children who are babies who are born with a PKD1 variant or a COL4A variant, actually the contents of the rest of the genome influence the penetrance or the chance that that rare mutation is going to cause disease. So we're in early days of this, and we still have not understood the full extent of this, but this is some of the primary data. So some of the uses of polygenic risk score may include inclusion to clinical trials. So we may want to divide people with a high, medium, or low polygenic risk score to different therapies. Or we want to maybe say among patients with IgA nephropathy, membranous nephropathy, kidney stones, is the progression over time to end-stage kidney disease differing by your polygenic risk score? It may influence our choice of therapies, and it may also help us with precision medicine. So right now we're still working on doing these studies in people outside of European ancestry. A lot of work is being done here at Harvard Medical School, where I am, in the Broad Institute, and I'm certain that over the next decade we'll be able to apply these polygenic risk scores to people across the world, particularly the southern global south. And there's also concerns about anxiety. I don't think we want all of our newborn babies to be born and given a risk of developing disease, because the 10 times increased odds of something that might happen 1 in 100,000 times is still only 10 in 100,000. So we need to be comfortable in communicating risk. So my last slide here is that it's increasingly clear that when we as clinicians are considering a person with kidney disease and their genetics, we should at least ask ourselves, is it important to contextualize the genetic mutation or the genetic condition within variation that exists in the rest of the genome? Will it be that one day we don't just do a panel test or an exome sequencing, but will we always do exome sequencing and polygenic risk scores to more fully predict and treat patients with genetic causes or contributors to their disease? So with that, I'll stop.
Thank you so much, Matt. So again, just as we're finishing up the three key presentations, pop questions into the chat box as we now transition to this last component of this webinar. But to open up the floor, as we discuss now, I was going to first actually throw to you, Nina. And what would you say, I think, on reflection in this past, few decades where there's been substantial, I think, progress in this space, what would you say have been the biggest things that you've seen that are the biggest advances that have occurred and or been implemented that were perhaps thought to be highly unlikely many years ago? What surprised you about the good things that have happened in this space?
Yeah, all in all, I think, it all started with the enormous technical improvements. Of course, next generation sequencing has brought us something that we could never expect. So when I started in genetics long time ago, we did karyotyping. That was all about it that we had. And so since, let's say, 2009, the next generation sequencing, so the improvement in diagnostic utility of genetic testing has been so impressive. I could never have predicted that. And with the identification of more and more genetic variants, of course, we also get more clues for therapy. And that will be, I think, the next decade will show us that this is really coming true, because we already, when the first genes were identified, I remember back in the days, the first genes for so the BRCA1 gene, but also Huntington's, and then, slowly also some genes for genetic diseases were found. Everybody predicted within 5 years we have a therapy for all of this. This appeared not to be true. But now I think in the next decade we will definitely see this, and well, as Ulla mentioned, all of the techniques in with the CRISPR-Cas, etc., that will be really something that will help also to to develop gene therapies and really make a difference. So I think all in all, it is the techniques that have come to us that have improved. And so the technical improvements are, in fact, the most important, I think, for everything that we have seen today, and also for the next decades.
Yes. No, I think we often would joke how the things that are driving the technology are less things for us to be primarily concerned with. The industry base that's driving technological innovation is doing that so well and independently now that we're just the happy recipients of that in terms of unit cost price, speed, and accuracy. And it's become such an autonomous component of this field in a way that we hadn't predicted.
Yeah, but of course, that yes, technology improvements are driven by industry, but industry needs us because the interpretation of the data is done by us, and so it's something we do together.
Yes, data without a lens is meaningless. So. And like I guess as Nina's mentioned, moving into the therapeutic space, and and there's a few questions about this. So I'll paraphrase a couple of them all together. That thinking around future gene therapies. How much do you think in this next decade that is hype or realism? Is this something we we should hold out and be thinking, yes, this is something to talk to our patients about, or is this something that maybe we're just hand waving?
Well, actually, I think if we look into other fields that are not genetic kidney disease, we already see this huge explosion of therapies that are coming forward. So I'm very confident that we'll also move towards these gene therapies in the genetic kidney field. And already so much is happening in this field. There's, ex vivo, in vivo. We're thinking about all these ways of how we can apply gene therapies, whether we do this subcutaneously or through other ways of getting to the kidney. And I forgot to mention this, but I really do want to mention this now because this is the perfect time for it. There's this wonderful new series, mini review series by Kidney International. So it's the Kidney Genomic Medicine Collection. And Nina also published there, but there's one specific publication out there on targeted gene therapy for rare genetic kidney diseases by Stephanie Cherky. And this is just wonderful. It summarizes pretty much what is out there in a very concise way. And this makes you very hopeful. And I also feel that you can tell patients about this, especially if they think about, should we go for genetic implantation, genetic testing, or should we maybe not, and see what happens when our child is 30 or 40, because we're moving towards these late onset diseases with PGD, and this might not be necessary in a few years from now.
Yes. And where do you, and that equipoise between, hopefully more definitive and curative type therapies with gene therapy in due course, potentially, versus in the shorter term, other, directed, but, maintenance type therapies, to treat a condition, but not necessarily cure it. Do you see a point where there's going to be a transition there, or, do you think it's best for us to mitigate risk by continuing to obviously develop, support and develop those kind of directed therapies in the short term? What do you think that landscape looks like?
Well, I also believe that we're already, kind of like personalizing treatment away, not think about gene therapy, but if you look in the outward field and all the trials that are out there with all the different pathways that you can, target, this is what we can do now, and this is wonderful. And I'm so glad to hear that all of this is happening. And this is also great for talking to with our patients. So even we already have so many options, but long term, I think it's a great time to be in genetics and in kidney disease. So yeah.
And then I guess, Matt, we're talking across a lifetime here. And as a pediatric nephrologist, I think your perspectives are really unique for very young children who might be presenting today, say, with the particular condition of interest for you, steroid-resistant nephrotic syndrome. For those with monogenic forms, what do you think the next 4 or 5 decades of their life looks like, and how is that do you think is going to be different compared to what you've seen before?
Yeah, so I think for whether it's steroid-resistant nephrotic syndrome or any other condition, I think there's increasing recognition that single gene or monogenic causes of disease are important to diagnose in and of themselves, and they can guide management, whether it's a targeted therapy against that gene or whether there's an existing therapy. And as the technological advances have improved and the costs have gone down, I think the barriers for people to do genetic testing has been lowered. So I think patients with a Mendelian form of their disease are going to be diagnosed earlier and have less of a diagnostic odyssey. I think it's also possible that moving forward, there's been a number of secular trends in the United States that have encouraged clinical trials and pharmaceutical development for kidney diseases. So I think there may be a chance that patients will children and young adults will get enrolled into studies more easily, that they're available. And having an understanding of patient's Mendelian profile, genetic profile, may help us direct patients to trials that will maximize the potential of treatment or cure and minimize side effects that may render a useful medicine not passing. And I think moving on top of that with this polygenic risk, I think that the extent to which this is going to be useful remains to be seen. But now that we understand the concept on a research basis, we can start to integrate our Mendelian knowledge with polygenic knowledge. And perhaps that will help us explain why different members of families have different progression of the disease. Or potentially, there's a question in the chat, which I think is very important about, it's a heck of a thing to put on someone, put a polygenic risk score on a newborn or a baby. But if over time we do research and we say among individuals with a mutation for primary hyperoxaluria or PKD, if you actually have a very low polygenic risk score, you actually won't get the disease. That would be very helpful to a family. Conversely, there are polygenic risk scores for things like venous thromboembolisms, clots, heart attacks, stroke. So maybe if someone presents with nephrotic syndrome, even if they don't have a Mendelian cause, if their polygenic risk is for higher odds of getting a clot, maybe those individuals might be put on anticoagulation therapy. So I think that overall, I'll just add one more thing, is that increasingly we'll use different technologies, whether it's long read sequencing, whether it's transcriptome first diagnostics. We will continue to uncover those edge cases of patients with genetic disease that we're blind to right now. Stop there.
And I think that's a perfect, thank you so much, Matt. I think it's a perfect segue too, and I pose this to the whole panel of how do you think we will be best placed to communicate to patients and families the application potentially of things like polygenic risk scores as we move from this fairly highly deterministic kind of outcomes in monogenic disease to a much less deterministic or rigid relationship to phenotypes with polygenic scores, where there's risk, but it's not an assurity. It's not a fundamental destiny. How do we best communicate that to people, and how do we manage concerns and anxieties that might arise?
Yeah, that's a really good question, Andrew, because that's in my experience, it's always difficult to communicate uncertainties actually to patients. So I remember also when we still had these microarrays, and we found some let's say a microdeletion in a patient, and then for instance, and this was another disease, for instance, a patient with intellectual disability, and we discovered such a microdeletion, but then the microdeletion was also found in the father, who was actually completely healthy. So then we discussed this with the father and the mother and said, this microdeletion is probably not the pathogenic one. But still, the father went completely crazy and ended up in a psychiatric hospital because he was afraid he had something really, really weird going on. So this gives you an example how difficult it is for patients to really understand the context of what we find. So this, of course, we need really perfect genetic counseling for this, but then still, people can sort of go on with this uncertainty, and it almost gets its own life, and it's very difficult to handle that for some patients. So I'm not sure how this will end up, but maybe Matt has also an idea about this.
Yeah, I'd just like to briefly add that the folks who are listening here, the three of us are experts, and we deal with a lot of black and white, but we also have a lot of awareness of these exceptions. The fact is that there's very many Mendelian diseases which are deterministic, and which you can look at a single genetic change and you can make a lot of predictions. So I think that what we're talking about, at least what I've talked about, polygenic risk, is going to be important, but it's not going to completely replace a lot of the advice we're giving now. And a lot of the things that we've learned over the last 2 decades are going to still be held in play. We're just going to have to get a little bit more precise in specific situations. And the second thing I want to add is that a lot of discussion about risk occurs when we're thinking about people who are walking around in each of our cities or towns where we live. We as clinicians are taking care of patients with the disease. So automatically, when a person comes with a kidney disease, it changes a little bit about how we think about risk or causation. And that I'll just stop there.
I just let me just maybe add just a little to this. I think if we look at how helpful PGS can also be, we can see this in the cancer predisposition. Is if you, for example, have a CHEK2 variant and your risk is already, we already can't really say how high your risk is. So maybe the polygenic risk score then will help us to actually determine and pinpoint better how a risk will be for a patient. So I think it can also go the other way, that it gives you more certainty than uncertainty.
Yes.
Yeah, hopefully. But again, I think that the challenge that lies ahead is that, the real clinical utility of these PGSs is still not determined. And as Matt mentioned, this is of course part of large studies that are going on now. And as soon as we have that proven, that you can really use it in an individual case and not only at the level of cohorts, I think then indeed this will definitely change. So there I really agree with the two of you.
Just popped up quickly the slide for CME, just for the audience to have plenty of access to in this last 5 minutes as we're finishing up discussion. But I think as well, it's interesting. I think that those things around therapy that you mentioned, Ulla, and I think the immense hope that we have in that space as it continues to develop may be some benefit here. I think particularly in some areas, say like in cancer predisposition syndromes, which are obviously monogenic but at-risk syndromes, where there's a lifetime risk of developing, malignancy or kidney cancer, but it doesn't mean that everyone will. And the way I care for a large number of families with those conditions, and tend to actually flip the risk and kind of talk to them not just about a 20% lifetime risk of developing kidney cancer, but rather an 80% chance that they won't. And we manage that risk, I think, from a guideline perspective, through screening. And we talk about management of risk, but not removal of risk. And I wonder if that's an area, I think, those skill sets that we already have in our back pocket, we'll bring back, I think, and be managing and using them in spaces like this around traditionally, quite monogenic diseases or new things that we're predicting with PRS in the next few years. I hope that we get to a point where, I guess we've all heard that joke that, for instance, pharmacogenomics, and thankfully, obviously in other parts of the world, such as in Europe, they're leading the way. It goes from being perpetually tomorrow's solution, but it's always tomorrow's solution, to being something that actually becomes today's and is implemented into practice. Are you just touching on pharmacogenomics? Is that a thing that or a tool that any of the three of you have seen entering into practice or research experiences with that as one of these a polygenically based clinical intervention that might hold promise?
Yeah, so in my department, we are actually using pharmacogenetics now. You probably know that. And we've started this, so we first did this in large population cohorts, but now we're starting to implement it in clinics, first with now at the hematology department, but the next one will be transplantation. So that would be interesting. And of course, this is all still part of research. So we're doing implementation, but we want to find out, of course, if and how it works. But we are very optimistic about this. So hopefully the results will come out soon. And I can tell some more about it.
And I think that the more patients that are entered into studies, or the more population-based cohorts, whether it's FinGen or the UK Biobank or health system-based EHR studies like Geisinger or at Vanderbilt or at Boston Children's, the more we can lay genetic information on top of what we're seeing in the real world. And it's very crude, our doses of medicines or our choices. And I do think that there will be a future in which pharmacogenomics could point us towards the appropriate diuretic or the appropriate antihypertensive or the appropriate immunosuppressant medicine to give our patients, not just which class, but also the dose. And this degree of precision will help our patients quite a bit. But we're not there yet, but we still need to accumulate lots and lots of data. And as a pediatric nephrologist, a lot of work is done in adults, and we need to be able to really bring this to children as well.
No, I totally agree. I believe that this will become more and more important, even though you also see different examples, for example, with tamoxifen, and where we used that for a while and then went away from it again. So it's going to be exciting to see what happens.
Yes. And just in closing, I guess these tools, a key part of it is in addition to that evidence generation for utility and benefit, there's also the clinician skill and clinician comfort. How comfortable do you think we're going, particularly as nephrologists, both pediatric and adult, how do you think we're going? Do you think we're on track for us to, and our colleagues, more importantly, to feel comfortable with potential utilization of these kinds of things, like pharmacogenomic testing, as that evidence grows?
Yeah, I think there's a long way to go, even with polygenic risk score pharmacogenomics. Even the idea of this might be genetic, think genetic, and the role of genetic testing is no longer solely in the hands of geneticists, and we as nephrologists are challenged, and it should be a goal to bring up our level of literacy to even do the basics. I'm not sure how we're going to get there, but folks on this call who are listening, the moderators, I think we're all going to have to contribute in ways to get us up to speed.
Since I'm not a nephrologist but a geneticist, I must say that I've seen real improvements in the recent years. So you're doing great, guys.
Thank you.
I think that's a great point. This is a space which it fundamentally rests upon partnership, and I think that those very strong boundaries between different specialty groups, even between pediatric and adult nephrology, I think are thankfully becoming more and more porous, and we're working together as teams, including genetic counselors, and diagnostic laboratory staff, in ways that perhaps 20 years ago was not really the way things were. And I think that, from things I've seen as well, I think that's been a major progress and is continuing to move forward. I remember 10 years ago, there was such great, fear is a strong word, but I think it's something in that realm, that mainstreaming would relegate the role of clinical geneticists in this space to being more minor. And thankfully, I don't think that's occurred at all. I think instead it's actually brought them to the center and actually are the key subject matter experts who in supporting nephrologists in mainstreaming genomic testing and information. And that spirit of partnership is just so key. And I hope to see that continues to build over the next few decades as well. Now, we are coming up to the end of the hour, so thank you so very much to all three of you, Nina, Matt, and Ulla, for this webinar today. I've popped, we've got the QR code here for the CME credit, so please, to those who've attended, don't hesitate to click on that and get offline the email with those next steps to potentially get your CME credentialing and certificates in the coming weeks. We're very thankful for everybody to have come along today, and thank you most especially to our three incredibly esteemed panel members, and for your interaction and your thoughts as to where we're headed. This is, as I mentioned, the final of a series of 4 webinars in this series, the Renal Genetics and Kidney Genetics Education Program. It's been fantastic to deliver this over the last few months, and hope everybody has gotten lots of use of it. And wherever you are in the world, hope you have a wonderful morning, afternoon, and evening, and thank you for attending.